very entertaining 2 days of deliberations that are going to help us improve the health of our adolescents by strengthening programming. Uh, this will be a very exciting opportunity to share experiences and learn from one another. I will be, co-chairing this first session with Dr. Elena Magongo from the Uganda Ministry of Health, and myself, Edward Bitarakwate. I work with Elizabeth Glazer Pediatric AIDS Foundation in Uganda. I'm a strong child and adolescent advocate, and it's my pleasure, to kickstart us on this very first session of the 2025 PAHLCA conference. Without further ado, I'm going to invite Dr. Elena to take us on by giving some opening remarks and inviting the Ministry of Health, Uganda. Thank you.
Hello, can you hear us?
Loud and clear. So, Dr. Elena, can you hear us?
Yes, Eleanor, you are muted. We should be able to hear you now.
You're all very welcome.
Help facilitate this session.
To the PAHLCA meeting 2025. We are very delighted that you've been able to join us. I'm now going to hand over to my co-chair, Dr. Edward Bitarakwate, to get us through this session. Thank you. Over to you, Dr. Ed.
Okay, thank you, Dr. Elena. The very first session of this 2-day event will consist of hearing from our local host, the Ministry of Health. We'll receive words from the STI AIDS Control Program Manager, Dr. Robert Mutumba, followed by our Commissioner for Communicable and Non-Communicable Diseases, Dr. Stavia Turiahabwe. After we receive those opening remarks, we will go into our opening session. This will be led by Dr. Lydia Mpango from Eswatini, who will talk to us about political framing and why children should not be left behind in the integration of HIV health services. After listening to that opening presentation, we'll also hear more about, what primary health care is, and this discussion will be led by none other than Anne Robbins. After then, we'll get into a discussion session and share our perspectives from those two key presentations. Without further ado, I think let's get on with it and listen to Dr. Robert Mutumba. Thank you.
Dr. Edward, I think Dr. Mtumba is having some network issues, but Dr. Stavia is on.
Okay. Uh, Dr. Stavia Turiahabwe, Commissioner for Communicable and Non-Communicable Diseases, you're most welcome to take the podium. Please set us off. Thank you.
Thank you, the moderator. Greetings to you all, and thank you for joining. Dr. Tria Westavia, Commissioner for Communicable Disease Prevention and Control, Minister of Health, Uganda. Happy to be here in the space for learning and how to prevent and control pediatric and adolescent HIV/AIDS in Africa. I want to take the opportunity to thank the organizers for this year's learning session and also I know we were supposed to meet in person, but because of what is happening in the global health financing space, this has not been possible. But nevertheless, the virtual space came to help in such circumstances. So happy that this is also happening. I want to thank the different countries that are here today with us. Thank you, and also to, I know generally across the continent we are making significant strides in the 95 targets for HIV/AIDS response. But the indicators, when you disaggregate them to look into detail what is happening among the children, among the adolescents, you find that the biggest gap in terms of access to reaching the 95 targets is in these age groups. So this learning gives us an opportunity to cross-fertilize each other in terms of what works, what are the best practices that we can get from across the different countries on the continent. And this really very important opportunity could not be missed this year around despite the funding challenges. So over the session today and also tomorrow, we should be able to at least speak something unique that will help us to turn around the tide in terms of the challenges that we are facing, so that we can improve the access amongst these very important age groups. The African population is a young population, and if we do not save it from the HIV/AIDS problem, it means we'll have a lot of burden in the near future. That said, I also want to encourage us to look at other opportunities that lie before this funding challenge. And I think still within this challenge, the HIV/AIDS space is the more funded space in terms of the resources that are available to the health system. So want in Uganda, we started looking at how best we can leverage that space. One, to improve access across the health system. So when you are looking at this child, you don't only concentrate at their HIV and its needs, but also if they don't have HIV, what else could they have? If you have managed to prevent HIV, what can disrupt their future? So is the adolescent and so on and so forth as we carry the response forward. So want to harness the power of people-centeredness in terms of service delivery, and the issue of integration is a very I would not say new, but something that can help us to really comprehensively address the health needs of the people that we want to serve. Thank you once again, Elena, for this invitation. Thank you, the organizers. I want to wish everybody good deliberations. Over. Thank you.
Yeah. Thank you very much, Dr. Stavia, for getting us going and for making those very key points, talking about the need for integration and the need for us to consider population health and not just look at individuals from the lens of one disease. Thank you very much. And I hope the deliberations of this week, of these next 2 days, are going to focus on those key messages that you've so well elaborated. At this moment, I'd like us to move into the opening session discussion. And I have the pleasure of introducing to you all Dr. Lydia Mpango. She is a medical doctor, a global health specialist, and very passionate pediatric advocate. She has over 20 years working in general clinical medicine, but also HIV, TB in both the public and private sectors in Uganda and Eswatini. Dr. Lydia Mpango has a special interest in clinical care and health systems and using evidence to improve long-term health outcomes of children, adolescents, and their families. Dr. Lydia, you're most welcome. Please take the floor. Thank you.
Okay, so thank you very much, Dr. Edward, and thank you very much, the PAHLCA team, for this opportunity to participate in this really, really great conference, great workshop. Okay, so my network is a little bit on the slow side, so I will request to switch off my camera for the purposes of the presentation. Thank you. Okay, so thank you very much. Just to the organizers, will I be sharing my own slides or will the slides be loaded?
Please share from your side in the meantime.
Okay. Mm. Okay. My apologies. I assumed that the slides would be shared from your side. Can you see my slides? Hello?
Yet.
Not yet.
Not yet.
Not yet.
Not yet.
Okay. Mm. Yeah, just sorry, a few technical challenges. Okay, to apologize for this. I seem to be having a challenge sharing from my side. Would you be able to share the slides from your side, please? Just so that we make up for the time. Yes, I do apologize. I'm having some technical issues putting
Yeah, sorry about that. Isaac, are you able to load them from the back end?
Just trying to find them in the mail, just a short while. Janet, you have a copy of them?
Can I send it by email I had sent them by email to Eleanor and the team, but I can reshare them.
Please resend. You can resend to Isaac Nakama and put my email address. I sent an email to you earlier today. I'll put the email in the chat.
Okay, thank you.
So, colleagues, participants, sorry about that technical glitch. I'd like to take the opportunity to again thank all of you who have made it. We are, over 130 participants, and we look forward to a very exciting session. We seem to have the slides up now. Lydia, please confirm that you can see them.
Okay, sorry, just. Jeez. I do not know what has happened to my screen. Sure. Yes, I can see them. Thank you so much. And apologies again. Yes, thank you so much. And apologies again for the technical glitch. Okay, as introduced, my name is Dr. Lydia Mpango, and I'd like to kick off this session by looking into why children should not be left behind in the integration agenda. Next slide, please. Okay, so from the data that we have, children are still lagging quite behind adults, as we can see from the 95, 95, 95 cascade amongst children 0 to 14, compared to the adults who are 15 and plus. We can see that across the 95, 95, 95, children are really lagging behind. From UNAIDS data, we also know that about children account for about 4% of our HIV prevalence, 10% of our HIV incidence, but 13% of HIV-related mortality. We also know that when we take a look at where infections are coming from, we still have about 50% of the infections in children occurring during breastfeeding. So this variation in the progress towards the 95, 95, 95 targets between children and adults might delay the achievement of set targets across our different countries. Next slide, please. Next slide, please.
Apologies, the slides are stuck. Let me still try to.
Okay, thank you so much. Next slide, please.
Janet, while sharing the slides,
So I think we
you
can
press
continue our
you
presentation.
press Shift Control Alt H to have that picture which is blocking the view. And if it does block the view, just click right in the slides. The slide should be open.
Okay, so thank you very much. Service integration for children. Next slide, please.
Click right in the slides, in the slide itself. Yes, thank you.
So service integration for children involves delivering health services in complementary and coherent ways so that people get the care that they need in ways that are effective, efficient, and equitable. And we get this from our UNAIDS definition. The progress on reducing preventable child deaths and increasing ART coverage in children living with HIV in sub-Saharan Africa, though improving, has been slow. And what we have is our delivery of health programs for children are often siloed in specific intervention areas that are focused on specific areas like HIV, TB, nutrition, immunizations. And this is really due to the organization that we have within our ministries of health or within our facilities, but also due to allocation and regulation of the donor funding streams that are available. In order to attain the integration agenda in children, we need robust child-focused systems and policies, which will involve governance structures, procurement mechanisms, accountability frameworks, and local ownership and accountability. Next slide, please. Okay, so thank you. So We have here a timeline of the service provision for maternal, newborn, and child survival in HIV programs. And a lot of the integration that we have has focused on synergies, and this is from national to facility to community level. And we do see quite a bit of integration that is already going on, and service delivery has been optimized through different programs, like we have the Integrated Management of Childhood Illnesses, IMCI. We also have the Integrated Community Case Management of Childhood Illnesses, which looks beyond HIV into pneumonia, diarrhea, and malaria. In many of our country programs and our facilities, we have integrated nutrition, growth monitoring, and supplementation. We've also got our expanded immunization programs. And then we also have got testing and care for the HIV-exposed children. And these are things that have already been integrated, but we still need to strengthen some of these programs. Next slide, please. So our children face quite a number of unique barriers when accessing integrated services. And so much like what we have seen in other areas of HIV and child health, we require child-specific considerations. Non-integrated HIV prevention and care services will lead to missed opportunities to provide essential healthcare services. And integrated services will reach those that we seem to have missed through our traditional programs like PMTCT. A one-size-fits-all approach to integration will continue to leave children behind because of the specific and very unique barriers that they face. Next slide, please. So we do have studies and meta-analyses which really provide the evidence of the interventions for integration of HIV services into child health. In terms of HIV services, we've got diagnostic testing for the mother-child dyad. We have linkages to ART, PMTCT services, and also services for the HIV-exposed and infected infant. We also have got child interventions, as we've seen before, that span through the whole care system, from outpatient services to inpatient services, community programs, and even nutrition. And what the studies and the evaluations that we have done have shown is that there is a great acceptability of integrated services by patients, caregivers, and providers. Also, there's improved healthcare worker capacity, which speaks to the practice that they do within our programs. We also have got improved service coverage, not just for the child, but for the mother and even within the family context. We have age-appropriate, child-centered, holistic care. We also have improved health outcomes, and we have seen this with our reduced infections, improving viral load suppression, continuity in care, and even mortality. We also have improved non-HIV health outcomes, reduced costs and cost effectiveness, and also it has provided the platform for research and innovation. Next slide, please. But having said this, we still have several gaps that remain. Most of the progress that we have seen has been owing to our very strong PMTCT programs, and that has given us the gains that we see in the pediatric HIV response. But in terms of testing and diagnosis, we still see delayed infant diagnosis. We see limited access to infant diagnosis. We see delayed initiation, inadequate index and contact tracing for the child and even in the context of the family. In terms of treatment care, though we see improvements in terms of access to formulations, we still have got to expand this for our children. Also, there's an adequate supply of both formulations and commodities. We also have got capacity gaps And this is affecting our retention and care, especially through the different transitions that our children go through, from infancy to childhood, childhood to adolescence, and even into adult care. In terms of differentiated care, we still need to strengthen our family approaches in order to provide holistic support and also adolescent-friendly services. We also have got structural challenges like inadequate resources and infrastructure in our different countries. And of course, across all the cascade of these different areas, we should be promoting community engagement. So these are some of the gaps that still remain for children. Next slide, please. So I really love this slide, and we got this from PATA, and I think that it summarizes very well what we want to say, that we do not want our children or adolescents to be left behind, and we have seen that the evidence that indicates that integration of HIV and child health services is an effective way to synergize and optimize existing health platforms. And this will help us to successfully achieve and sustain positive outcomes, both in the long and the short term. Our children need a more coordinated, effective, efficient, and comprehensive patient-centered and integrated care. And this we need to do right, we need to do it together, and we need to do it now. Thank you. Next slide. So these are some of the references that you can feel free to read. Thank you very much for your attention.
Yeah. Thank you very much, Dr. Lydia, and for that very good entry presentation, and thank you for recovering from those technological hiccups that we had at the beginning. And I think you really set the stage for the next 2 days. We're all talking about integration. While we still have gaps in service delivery, still have gaps in the quality of the work that we do, and shall children be left behind even more when we integrate? Participants, ladies and gentlemen, I'd like to introduce our next speaker, Anne Robbins. Anne Robbins is a familiar name for many of you. Anne is passionate about strengthening health systems and has worked in this area in a management capacity for UNICEF, the WHO, the UK government, and with international NGOs. She has over 30 years of experience in public health and is a public health consultant. She's worked to strengthen primary health care through health finance, human resources for health, and supply chain in Kenya, Ethiopia, Uganda, Cambodia, the Middle East, Malawi, and the UK. Anne's interest is in strengthening the quality of services along the continuum of care for mother and child health, including multi-sectoral household level interventions such as WASH, social protection, and education access. She holds a UNICEF Global Advisory position in health system strengthening. She's a public health specialist from the London School of Hygiene and Tropical Medicine, but also has an MBA and is currently pursuing a PhD. I think, there's no one better than Anne Robbins in talking about primary health care and what it means at this stage in time for the health of children and adolescents with HIV. Anne, you're welcome to take the podium.
Thank you very much, and a very kind introduction. I do appreciate. Are you able to share the slides your side? That's perfect. Thank you. So I'm delighted to be here this afternoon, and thank you so much for inviting me to speak. I feel really honoured. I'm going to talk a little bit about primary health care and health systems and the opportunities for HIV, and also the opportunities for primary healthcare and health systems to have more HIV within it. Next slide, please. So for the whole of health and child health, we are facing a situation where we have been focusing on interventions and diseases as an international community, and through this influence also government side. And this has worked really, really well up until about 2010. You can see on these two graphs, up to about 2010, the fall in both mortality on the left side and stunting on the right side was really quite dramatic. But after 2010, it kind of tailors off and the curve is a lot flatter. And unfortunately, it's really challenging now to make the curve really go down further because of the increase in population size and the demographic shift. So we have been able to contribute to mortality and stunting reduction through intervention and disease programming with ODA money and obviously government leadership, through some parallel services, some campaigns. But now really to close the gap, we need to focus on system strengthening because the government is the only institution that is able to close the gap. So for HIV, in terms of child deaths, there is quite a contribution from pediatric HIV, with 50% of children dying by their second birthday and 80% by their fifth birthday if not getting proper treatment, leading to 76,000 deaths globally, which is not small. Next slide, please. So we need to make the SDG shift to strengthen government systems. And there was a consortium of universities coming together, and they created something called the Lusaka Agenda in 2023 that said that both countries and international development assistance should use primary healthcare and health systems as a way to monitor progress so that all intervention and disease programs can join together to strengthen the system for sustainability, equity, and accelerating that mortality and stunting reduction on the previous slide. So we've all been trying to do this, but against the odds with all these compounding factors such as COVID and climate change and conflict, and the most recently, an unprecedented cut in ODA has been particularly challenging for all sectors, but especially HIV. Next slide, please. So UNICEF has been trying to make a contribution in this area, and we've moved through various different phases. I was explaining the MDG era. We're now in the last column, the blue one, the SDG era, where we really want to focus on sustainability and equity. We want to look at the second decade as well as the first, and we want to work with governments to accelerate domestic financing for the health and social sectors to serve children. Next slide, please. So in terms of measuring systems, we have lots of strategies, documents, and operational guides on how to run immunization and how to operate PMTCT, etc. But in terms of how we strengthen a system, we have much less to go on. And as I work in the area of systems, I'm often here, it's all fine, Anne, but what do you do about it? So there was a framework, primary healthcare framework, created by WHO, UNICEF, and obviously all countries, and divided into three: multi-sectoral policy and action, primary healthcare service delivery at health center, district hospital, and community health, and then engaging with community-empowered communities. And within that, we have all the circles along the bottom: the supply chain strengthening, how to increase quality of care, how to monitor health workforce and numbers, and you can read the other areas: digital health, governance. And primary healthcare is multi-sectoral, obviously is really important for HIV response. So using the health service to reach children where there isn't social workers for child protection, ensuring WASH in schools, health centres and communities, improving diet quality and frequency through food systems, and you can read the rest. So really looking at the horizontal system that serves everyone. Next slide, please. This is where the colourful circle comes from. If you want to read the strategic and operational levers, there are 14 of them. This book is available at the link on this slide. Next slide, please. So across the life course, obviously there are many touch points for all child and adolescent services. But the point I want to make here is that integration for HIV is not new. And in many ways, you lead the way. So for PMTCT, for example, especially on the African continent, PMTCT has really improved the quality of antenatal care for all women. It's been really advantageous for all women to have that service within basic healthcare. Now we have to learn from this experience and translate it to pediatric care to really get the coverage rate up in a sustainable way. Next slide, please. This is how you measure when you're integrating against the primary healthcare operational framework. There is a monitoring framework, and as part of the Lusaka agenda, all countries and development partners came together in the World Health Assembly and agreed on 23 composite indicators to measure it. And this is the framework for that agreement. Next slide, please. And these are all the development partners. Some of them are not there anymore. For example, PHCPI closed as a project, and obviously USAID is not there anymore. But all the leadership comes together. Used to be under the Primary Healthcare Accelerator, now more recently under PHC 25 to 30, and there's a movement from the Kazakhstan Global Movement and others. Next slide, please. So these are some integration principles that I borrowed from the immunization team, but they are relevant also for HIV. So looking at these areas can really help come up with an integration plan. So for example, leadership and governance. Is HIV well known within the Department of Planning and Ministry of Economy and Finance and led by the Minister of Health or relevant minister for other social services? Is it visible and on the radar? Is it funded domestically and internationally? Are the supplies needed integrated into the regular supply chain? To give you an example, if some medication needs a fridge, is it in the immunization cold chain? Insulin, I know that's not an HIV medication, but it's an example. Health workforce, are there sufficient numbers and are they sufficiently capacitated to deliver? Are the information systems integrated so that it can be tracked and digitalized? And service delivery, if it's integrated, more geographical coverage can be made. Next slide, please. So HIV can bring so much to primary healthcare as well as the other way around. Primary healthcare strives to be multisectoral. HIV has always been multisectoral, so it would be great to learn from the HIV sector. I know HIV has a very strong community presence and can really contribute to system strengthening. You have a lot of experience in data and procurement that everyone can learn from. And with trusting relationships of government and partners, I know we're going to get there. Next slide, please. This is an example of an assessment done in Ethiopia, considering rolling out multisectoral services. They did a baseline assessment in a few about half the country in terms of districts, which is a lot because it's a large country. They were looking at, they call it the vital organs, staff, supplies, and a bit of money in the system to be able to operate. And they took the approach of actually doing a situation analysis for the system to figure out how to strengthen it and then what they could put through it. Next slide, please. That report's available if anyone would like to learn from it. So the key takeaways from today are It's really critical that we sustain HIV gains. Otherwise, we are going to backslide and all suffer. But it's important that we do this through country-led health systems. That integration is already happening and in many cases very successful, like PMTCT, and we need to transfer that into other areas such as early infant diagnosis and pediatric HIV. And I believe that the new medications allow for that to happen. We need to work together on this, both in terms of development partner community and government. Next slide, please. So integration is clearly needed, but the recent cuts in ODA are really accelerating and making it much more urgent. We are at risk of missing treatment for thousands of children, so we need to do it in a systematic way with government and development partners, following standards of quality and ensuring that we set ourselves up for the future. Next slide, please. So thank you so much for listening to me. My colleague Shafiq is on the call and is very able to help with questions also, and will be on the panel later. Thank you so much.
Thank you very much, Anne, and welcome, Shafiq. Participants, you've had, from two very important discussions or presentations. One highlighted why we need to ensure children are not left behind, while the second one, talked about successes in primary health care, but also successes in integrating HIV into primary health care with PMTCT as a case in mind. But we need to do that, through government-led interventions that ensure equity and ensure a march towards attaining the SDG goals. With that said, I think it's a good point in time to open this up for discussion. We already have a few comments in the chat, and I'll request Janet to log those. But would like to open it up fully. Please feel free to raise your hand and make your comment, question, or contribution. But also feel free to note it in the chat. I think the very first question came from Dr. Stavio, our commissioner, and this I think went largely to Lydia. And her question was whether the challenges that were mentioned were due to integration, or are they challenges that one needs to consider as we think about integration? That's for you, Lydia. Maybe that, can open this up as we wait to see who's raising their hand to ask. And Isaac, please just help me monitor the chat to see whose hand comes up. But over to you, Lydia, to just kickstart this discussion.
Okay, so thank you very much. And thank you very much for the question. Yes, so these are more of things that we need to consider, especially within the fiscal space that we are in right now, where we really need to optimize and try to create sustainable systems. So the challenges that we have are not due to integration, but they should be considered as we strengthen integration within the pediatric space, also acknowledging that there are even finer age-specific considerations that we need to put in place. Thank you.
Okay, as we wait for more questions to come in, I have one question for Anne. we usually look at integration in two different ways. One way is integrating HIV care into chronic care healthcare, which is largely secondary healthcare. But the other is integrating it into primary healthcare, like you've ably demonstrated that the prevention of mother-child transmission of HIV has done a very good job at that. What are your comments about chronic care, integrating HIV into chronic care? That's largely looking at NCDs and other related conditions. And what's your advice on implementing those two contrasting models? Thank you.
Thank you so much, and a great question. I think it's a problem that we all share, and it's a very, very serious problem. And we need to sit together with ministry colleagues to discuss the implications together. NCDs as a whole are a massive drain on the health system and very, very challenging to deal with. But many ministries are very resilient. I think the African continent was the best at dealing with COVID, for example, the best in the whole world, actually. So I know that there are innovative, creative, strategic planners in governments that can come up with solutions. I think also HIV sector has that strength in multisectorality and that community engagement piece. And so the burden perhaps is not only for the health sector, but also for households, families, faith-based groups, especially because chronic care, obviously medical care is only one part of that. You have the mental health side, you have the economic side of people that cannot work, of children that don't have school fees. So perhaps we can learn from that in terms of multisectorality. There's no easy answer to this, and but I think together discussing and making a systematic plan can help. I don't know if Shafiq has anything to add to that.
Would you give me the podium for a moment, Edward?
Oh, yes, sure. Shafiq, please go ahead.
It's nice to see you, and it's nice to see so many colleagues and friends joining online. And again, congratulations to Eleanor and the whole team at PAHLCA for bringing us together in this virtual forum. I wanted to explain something that struck me, recently, which is we often talk about how we've been so successful at integrating PMTCT, into the public health or rather primary health care to the extent that, every ANC site can now deliver on PMTCT. And that's really been the linchpin of why we've achieved this success in the very high rates of coverage for pregnant women. But the important point is that as far as the antenatal care platform is concerned, HIV is not a chronic illness. HIV is not a chronic illness for the antenatal care platform. They test mothers and they test for lots of other things, anemia, proteinuria, blood pressure, diabetes, gestational diabetes, etc. So along with the battery of other tests, they test for HIV and they provide treatment for HIV. But after delivery and after the early postnatal care visits, their job is done, and that client goes on to other services for her chronic HIV needs. So it was a much easier task in a way to integrate PMTCT into every ANC, into the PHC layer for antenatal care, because it was a very concrete, time-limited intervention that we were proposing. And when it comes to pediatric care and treatment, we obviously need to deliver, in a very different way to keep children engaged in care. And I think we will expand much more on this over the course of these next couple of days to figure out what we need to do to make that happen. But the mind shift is important, you know, to go from the relatively time-limited integrated interventions that we have achieved for HIV PMTCT into the chronic interventions that are needed for sustaining children living with HIV who need chronic care, you know, repeat prescriptions, referral if there are issues that can't be handled at the primary level. Those are the structures that we need to think about, and plan for, and establish to effectively do this integration of pediatric care into the primary health space. Yeah. More on this later, I'm sure. Thank you.
No, thank you very much, Shafiq, for that. And, you know, there's another question in the chat, you know, that goes out to both Anne and Lydia. And the question is about your thoughts on pediatric HIV, TB, and NCD integration in conflict settings. So this is looking at obviously, you know, special circumstances where, you know, we face displaced populations. You know, what are your thoughts about that? And I'm hoping that David, who posed this question, may share some experiences. You may have some experiences in mind. We also have another question specifically directed at Anne, you know, where Moses asks if you could share some thoughts on the role of universal healthcare and private health insurance in sustaining HIV services. So I think this goes more to the financing options, you know, that a programmer, a government needs to consider while thinking about sustainable HIV services. Over to you both. Thank you.
Thank you. I mean, it speaks to the heart of integration, really. So in terms of humanitarian response, obviously the very acute phase is going to respond to the nature of the emergency itself, whether it's a flood or explosion, famine. But within that, the needs of people with who are HIV positive need to be taken into account, and that needs to be written into all the response guidelines in the emergency preparedness phase. HIV needs to be in the essential care package for population health because it's a public health issue of concern. HIV or range of treatments needs to be in the health insurance policies as conditions that can be claimed against. This is a lot of work. There are so many different areas of integration to consider. And I guess it's very country contextual as well. I'm in a global role, but I know in some countries, HIV is already in the health insurance package and people are already claiming, and others it's not. And so obviously priorities need to be chosen according to the country context and priorities. Shafiq, have you want to add?
Yeah, nothing more to add from my side, Anne. I think you've captured it nicely. But clearly, this is the tough question. We can't achieve any of this without dedicated both funding and political will from governments to make this happen.
And in the countries where I've worked, very often the HIV community, because of the financial streams, have been a bit separate from other ministries. And now is the time to sit together. Many ministries have active lobby movements for both finance and health insurance and humanitarian response and emergency centres. So it's about getting HIV representation in those departments to get the political will that Shafiq is talking about.
Thank you. Lydia, do you have anything to add? Any additional context?
No, I think that Anne has said it really very nicely, but I think that there has to be a lot of advocacy, because remember, we are dealing with a very small population within a bigger population of adults. So that advocacy has to be really, really intentional and deliberate. But I think Alex has covered it very well. Thank you.
Yeah. No, thank you all. I'd like all of us to give an applause, to our three speakers. I know it's a little challenging to upload people, but I'm sure we are able to to do that virtually through Zoom. So a big round of applause and hand claps for our opening session speakers. The conversation continues. We're a little over time, about 8 minutes over time. And we still have one question in the chat. It's really an advocacy question about how we can lobby governments allocate at least 15% of their national budgets to health. We'll park that. I'm sure we'll have some government colleagues who may have a few ideas about, how we can raise more resources. But this is a question for all of us. Allocative efficiencies keep, coming to mind when we look at reduced external funding and the need for us to refocus our efforts. We are a little over time. I saw there was one hand coming up. Isaac, have you seen any other hands? I saw a hand pop up. But if you cannot
you
allow,
had a hand from Susie.
Okay.
But she put it down very quickly.
Okay, so Susie, I hope you'll still have an opportunity to pose that question to the participants. But allow me at this time to move us into the next session of country case studies. And I'd like to invite Rodrigue Coffey to lead us through this session. Rodrigue, please come on and take the baton from me.
Okay, thanks, Dr. Edouard. I'm going to switch in French, so kindly click on interpretations. Bonjour à toutes et à tous. Merci de nous rejoindre donc pour cette autre audition donc de notre webinaire de collaboratif et de partage autour du VIH donc pédiatrique. Je suis donc Rodrigue Coffey, coordinateur du réseau Grandi Ensemble. Je suis basé à Abidjan et j'ai donc la responsabilité donc d'aider donc pour cette session en lien avec les études de cas à pays. Nous aurons donc des partages qui vont se faire autour de 3 pays. Et ensuite, nous aurons dans les discussions de travaux de groupe qui permettront donc à chacun, à chacune de contribuer un peu avec des éléments de questions, d'échanges et de discussion. Nous aurons donc des contributions qui seront faites de 3 pays. Nous aurons une contribution qui sera faite de l'Ouganda. Après celle de l'Ouganda, il s'agira donc d'une contribution en fait de Botswana et suivra enfin une autre du Nigeria. Alors, Isaac, il ne sait pas si c'est OK. Nous allons donc partager donc l'étude des cas de l'aspirant de l'Ouganda, présenté donc par Cordelia Katorebe. Isaac, quand tu veux.
Dr. Cordelia, over to you.
Yes, please. Elena, please share the slides.
OK.
Okay, good afternoon, good evening, everybody. I hope I can be heard. I was given just a few minutes to make a presentation, probably to provide some of the framing remarks of the work that we are doing in Uganda. My name is Cordelia Katurebe, and I've been leading on the process of integration from our country. And I'll just be going through a few slides to share what our integration plan looks like, the framework, and the implementation process, and some of the key lessons we've learned over the last 4 months of implementation. And the title of my work is the operationalizing of integrated person-centered healthcare, the experience of Uganda. If we can go to the next slide. Uganda generally has been, integration is not new, and I've heard this from previous speakers. Our national essential health care package for Uganda of 2024 clearly spells out that our mode of delivery within our public health centers and in our primary health care facilities, our mode of delivery of services is in an integrated manner. And this fits in line with our National Development Plan, the current version, which also talks about provision of integrated health services, and actually even under the social pillar and the human capital development pillar, where we need to see integration not only of health, but even other services that come around. And the implementation or the guide for the healthcare workers within our country is through the Uganda Clinical Guidelines, which is also integrated. So in Uganda, while we look at integration coming in, it has always been the normal. However, we also know that we have had siloed vertical programs, like in all other countries that have come in and also had their gains. The HIV programs had been vertical. We had programs for NCDs that were vertical. We had programs for malaria that were vertical with benefits, but we have also known that they have created some fragmenting of the healthcare and limiting the healthcare worker capacity to be comprehensive. And of course, with the funding landscape that is now changing, and I think all of us are aware of what happened earlier on in the year, the donor assistance continues to get smaller, and the demands from the government continue to get higher. But ultimately, the government's responsibility is to provide care for all the citizens. So it's against this background that Uganda has got a renewed focus on integration back to what it was doing previously. And as we move to the next slide, we have now then developed our integration framework. And in the next slide, our framework for implementation is based on the World Health Organization framework, where we have considered the health system blocks as the key drivers for implementing integration in the country. In relation to today's discussion around children and adolescents not being left behind, what does integration look like for them? Our framework for the country is based on the system blocks. And for purposes of this presentation, I want to focus on the slide, the particular area around service delivery. And in service delivery is where we are looking at the different populations. Within our guidance, we recognize that certain populations, if we are going to provide equity of services, if we are going to ensure that people are getting comprehensive services, if we are going to keep the benefits of our HIV programming, for example, providing differentiated services and looking at different subpopulations within the service delivery platform or pillar of the health system blocks, is where we recognize that children and adolescents should not be left behind. And our guidelines are going to be very clear around how we promote coordinated services, continuous team-based care, which is what we have learned from our HIV programming across the providers, smooth patient transitions, and comprehensive care platforms as we see appropriate. And this considers differentiated service delivery, focusing on the subpopulations. That aside, the country provides an implementation framework that ensures that we have robust systems for ensuring for financing. For example, how do we ensure that as we do integration for children, that the resources to support that integration for that unique population are actually available. What are going to be the discussions around integration in recognizing that children and adolescents are a special population? What about the supply chain? What are the considerations that we are going to be making to ensure that through the public health care system or the primary health care system, we know that the supply chain will be robust, but also taking into consideration that there are unique populations that have unique considerations. For example, the different formulations that are still needed, the different drugs that might be needed for the children, and even their supply chain that would be even needed. When we also get to the systems, again, we have made very good progress around this for the children. And we know that in the HMIS, countries have already made very good progress in ensuring that the subpopulations and the data, the age groups for children are actually catered for both children up to the adolescents. So this is going to be maintained. The community engagement, again, back to our DSD models, what is going to be unique for children and adolescents within the broader framework of the systems for integration. And likewise, when we look at the workforce, what are those competencies that we want to enhance as we now get into domestic funding, as we get to looking at the governments taking care of children? What are the investments we are going to make to ensure that a primary health worker has the adequate skills and competencies to look after a child and an adolescent? And then, of course, the bigger aspect of governance and leadership. So in the country implementation framework, this is what we have clearly defined. And we can go to the next slide that looks at our critical stakeholders that are on the table, looking again at the aspects of the framework. That our framework cuts across all levels of our health facilities. The integration guidelines and the practical guide starts right from the community, builds up into the villages, and then across the different levels of the health centers, as we can see from the health center tools, which are at parish level, up to the national referral hospitals. And within there, we have the critical stakeholders that are involved in this integration. Government of Uganda taking the leadership and stewardship, working together with partners, the civil society, engaging the private sector, and all other leaders that are coming in to look at the integration. The next slide looks at the implementation process. And again, just to describe what we have done practically as we try to engage and ensure that the children and adolescents are not left behind. Like I mentioned, all these processes, when we create guidance, we are mindful of the subpopulations that should not be left behind, and really learning from the successes of the HIV program, but also taking the opportunity that integration brings on board. How do we enhance our robust systems within the primary healthcare settings? And to support this, we have a national advisory committee that continues to guide the country on what the implementation framework for integration will look like. But we also have an operational task force that works at the grassroots level, ensuring that the feedback comes in from the communities, the feedback comes in from the healthcare providers at the facility level, to ensure that these populations are not left out, but that we continue to have quality of care and that the standards for integration are also kept in place. Further to that implementation process, like I had mentioned, the training and building capacity of the health workers is going to be very critical. In Uganda, we have already developed a training plan that is case-based, it is scenario-based, and particularly has a section where we talk about the subpopulations, the vulnerable populations of children and adolescents, and emphasizing how integration should happen within the chronic care settings, which is our standard of care. And we have ensured that the capacity has been rolled out and cascaded right up to the level of the districts, and eventually it will get to the level of the health facility. And we want to ensure that learning is happening and that institutionalization for integration happens through the ongoing mentorships and supervision that will happen, so that at the end of the day, we want to see the subpopulations of children and adolescents not being left behind, even when we have developed robust systems for chronic care to be provided. In the next slide, I'll talk about some of the lessons that we've learned. The next slide, please. So what are the key lessons within the 4 months of implementation? It has not been long. We are harnessing the successes of our HIV program, specifically harnessing the successes we've learned from how we have implemented pediatric and adolescent HIV care. And we want to build on the residual capacity from the health workers, from the communities, from the peers, and all the experiences to ensure that even as we go into the chronic care settings, we still continue to provide more care, but even build on the successes of having the primary health care structures being utilized. That is more skilled healthcare workers who are government supported, building onto the infrastructure that is already there, and all other aspects that come with the benefits of the primary healthcare. We have also learned that positive attitude is going to be very key, and there's going to be a need for mindset change, especially among some of the slow adopters. And we know that the whole of the ministry approach, we've engaged all the departments in the ministry from their departments and divisions to ensure that this integration happens, and it has been key in some of the things that we have learned. In the next slide, please.
Excuse me, doctor, it's remaining less than 1 minute.
Yes. So these are some of the challenges, the logistics. Of course, for chronic care, we can see the issues of NCDs. Change management is going to be very key. The reversals that needed to decongest higher level facilities, limited technical capacity among health workers, and the funding that will be needed even to support capacity development. I want to thank you very much. I think that was the last slide, and thank you all for allowing us to make our presentation. Thank you.
Thank you, Dr. Cordelia. Merci pour cette présentation, pour ce point d'étape sur les expériences et le modèle d'intégration de soins de VIH pédiatrique dans les soins primaires en Ouganda. Notre prochain intervenant, donc, nous allons donc nous diriger maintenant vers le Botswana. Le Botswana, donc, avec Dr. Lynn Chihare. Je vous vois en ligne. Docteur, est-ce que vous m'entendez? Can you hear me?
Yes, I am online.
OK, thanks, docteur. Donc, merci, docteur, vous avez donc la parole pour 5 minutes. Over to you.
Good afternoon. I'll be presenting on behalf of the Botswana team. As a way of background, I'll be presenting on the integration processes. So a small background is that Botswana's primary healthcare system Hello.
Oh, Isaac, can you share the... Okay, thank you, doctor.
Okay, thank you. So Botswana's primary healthcare system has evolved significantly since its independence in 1966 from a primary curative urban-focused approach to one emphasizing prevention and community participation and a wide range of service available to all. This was the case until we had the HIV epidemic, which inadvertently changed our response to a more responsive curative. However, we have now moved back to primary healthcare and in what we call the primary healthcare revitalization. With our population of 2.3 million, we have notable progress in strengthening our healthcare infrastructure and advancing public health outcomes, particularly in the area of HIV prevention and treatment. The country has a robust network of 819 facilities, ensuring that 95% of our population lives within 8 kilometers of a health facility. We are currently moving towards decentralizing primary health care in Botswana to local authorities so that we enhance access and responsiveness. We are aware now that communities are different, and therefore decentralizing them to local authorities provides a more context-specific approach to primary health care. And it's also notable that in our country, 83% of our population relies on free public health care services, while 17 rely on private healthcare facilities. Next slide, please. Next slide.
Isaac or Dr. Eleanor? Next slide, please.
It's a bit stuck, but
okay.
let's try to unshare and share again.
Okay. That's good. Thanks to all for your patience.
Of pediatric and HIV care. Implementation approach. We do.
Okay, Dr. Lin?
Yes, our implementation. Can we do the integration frameworks before the implementation approach? Okay, so the integration frameworks that we adhere to in Botswana, yes, we do, as a holistic, utilize the system blocks of the WHO, but honing down to the frameworks that we use in Botswana, we do use the clinical integration and service integration. So clinical integration in our primary healthcare truly focuses on coordinating care within our clinical setting among different healthcare professionals. If you are familiar with the kiosk, supermodel, and shopping mall models, in Botswana, our lowest healthcare point of contact is the mobile stops. So they are similar to our health post, which utilizes a kiosk model. That is to say, when a client accesses this kind of service, they are able to get all their services from that healthcare provider who is within the facility. As an example, in the clinic, if the client is coming for HIV services, they will be able to get them from that provider. If they are coming for ANC or IMCI or any child issue, they'll be able to get it from the care provider who is present. In a supermarket model, which is what we apply in the clinics, the client will be able to access a variety of services from different healthcare professionals, which is just a matter of moving from one consultation room to another. Whereas in a shopping mall model is where the client moves from unit to unit, but with all housed within one healthcare model. Service integration then recognizes that we are not able to have all the skill set in one place, and therefore this emphasizes on coordinating different healthcare services and organizations to provide a seamless patient experience. Within our different levels of care in Botswana, we have different packages to which every level of care offers. And we also have defined referral pathways to ensure that clients do not find themselves lost within the different levels of care as they are accessing. And therefore, these two, clinical integration and service integration, we really focus on these to ensure that our clients get the services they need. Another example with our service integration would be the fact that in Botswana, we do have or practice models of excellence. And a point in case for pediatric HIV care is our Baylor Center of Excellence. It's only one in the country. And therefore, to ensure that clients do get equitable services, the skill set is cascaded throughout the different levels of care, even through referrals and just a mentoring of clinicians. Next slide, please. The implementation approach, therefore, then really focuses on the workflow integration. If you may be aware that in Botswana, when HIV started, we had, or we still do have, standalone HIV services. These are really a bit away from integration, but what we do within the HIV standalone services within the clinics, clients are able to access care beyond HIV services. We have noted that a client, or at least a client, is more than a disease, and therefore we focus on the patient offering other care outside HIV services within what we normally term our infectious disease unit, so they are able to access other non-communicable disease services even within those. And then we have moved a step ahead in our workflow integration to ensure that even outside HIV defined spaces, clients are able to access the HIV continuum of care wherever they are. That is very important for our children and youth clinics, because we do note that they need an array of services beyond HIV services, and therefore wherever their point of contact, they'll be able to get all the services that they need. This also helps in terms of focusing the care of the health professional. We also have really leaned towards standardized guidelines. HIV care in Botswana is heavily guideline orientated, and therefore we ensure that health professionals go through this standardized training. This ensures that irrespective of where care is accessed, the care is equitable and the same for specific issues that are public health problems within our country. And therefore, it makes integration of services much more easier once the guidelines are standardized. We also lead towards the minimum packages wherever you access services, be it prevention and treatment care. This also is a case beyond HIV services in issues like IMCI, sexual reproductive issues, and baby nutritional issues. Capacity building is also part of our implementation approach, because in Botswana, we try to ensure that all healthcare workers undergo specific post-qualification training, particularly for HIV care, as well as IMC care in our country, to ensure that the standardization is ensured across all the continuum of care. We are not unique in our country. We also do have challenges of a shortage of staff, and therefore when we try to integrate, we also employ the task shifting element to ensure that services are provided wherever the point of contact within the healthcare system is. Monitoring and evaluation as well as surveillance is a key factor that defines our scope of practice, our scope, our target, and identifying gaps. Leaning towards HIV, you'd realize that we as a country have noted that adolescent girls and young women are a focus area, and that is really because of data. You can move to the next slide. So the issues of integrating care within the primary healthcare system has yielded good results, particularly in the HIV PMT space. as we are aware that Botswana has been able to achieve their gold tire in the path to elimination, making sure that antenatal care coverage is above 95. This is throughout the levels of care, even testing, as well as ART coverage. This is due to the robust primary healthcare integration of services that has yielded this effort, coupled with all the community engagements, education, healthcare worker commitment, and our partners as well as civil society, ensuring that a human-based approach within the community is achieved. The next slide. However, like the previous speakers have spoken to, integration is not without its challenges. We have experienced fragmentation of investments, particularly because in our primary healthcare modalities, programs have been significantly verticalized, which has caused the fragmentation of investments. We also, like I did allude to, the inadequate health workforce that we do have, but we do try to mitigate that through task sharing initiatives. Limited community outreaches. Our models of primary health care prior to our decentralization really focused on the health facility being the point of contact. We are therefore, as Botswana, moving towards a community point of contact through an investment in community healthcare workers to ensure that primary healthcare goes beyond a health facility. Delayed policy implementation is one of the challenges that we have experienced, mainly because of the didactic nature and the iterative processes of policy implementation or policy adoption. Supply chain and logistic management is also an issue that the country does face now and again. The data systems being paper-based has proved a huge challenge because, as we know, that technology makes things easier. We are slowly transitioning to digital systems as we speak. Next slide. So the next step really in terms of improving primary health care integration in particularly the PMTC space, is to ensure that we strengthen HIV and hepatitis B programming through integration. So most things we are trying to learn from the lessons learned in the achievement of the HIV gold tier. So to lean towards the lesson learned, also strengthening digital data capturing in our entire primary healthcare processes. Continued primary engagements and education, like I did allude to before, that we have now moved towards investing in community healthcare workers to ensure that the first point of contact in our setting is a community worker. Advocacy for continued political will. Botswana has been known as one of the countries that there is great political will, particularly so in the issues of HIV/AIDS. But a continued advocacy is a point to mitigate the complacency effect and a focus on sustainability. Thank you so much. I will stop there.
OK. Merci bien, Dr. Lin, pour ce partage d'expérience sur l'intégration au niveau du Botswana et pour ces différents éléments qui font aussi écho avec la présentation précédente par rapport à l'Ouganda. Nous allons donc terminer cette section sur donc, les partages de cas par rapport au pays avec le Nigeria. Docteur Etibio, je vous vois en ligne. Est-ce que vous m'entendez, docteur Ethiopio, pardon?
Yes, I'm here.
OK,
Yes,
parfait.
I can hear you. Please confirm you can hear me as well.
Yes, OK. OK, merci bien.
Okay.
Donc, je vous laisse donc la place pour donc, nous partager donc l'expérience en termes d'intégration du Nigeria. Vous avez la parole, docteur. Merci.
Thank you, Kofi, and thanks to colleagues on the call. My name is Dr. Etiwe Ehime, and I'll be making the case presentation on integration of pediatric and adolescent HIV services into primary healthcare in Nigeria. Next slide. So for us in Nigeria, I'll be going through this background. Next slide. We are a large country, and you're all aware we have an estimated 1.9 million people living with HIV. So in recent years, the country have made a lot of efforts to ensure that services are integrated. Just like what Dr. Cordelia said, in Nigeria, we've been talking about integration even far before now. And we have a very broad primary healthcare system that is operational in country. Next slide. And so, still based on our epidemiology, our prevalence is 1.3% from our NICE study that was conducted in 2018 between the ages of 15 to 49. For children less than 15 years, our prevalence is 0.1. And you can see our incidence rate is 0.08. And the major drivers for our epidemic is the key population. Currently, our PMTCT coverage has increased to 62%, and we are happy about that. Next slide. So there is need for us to sustain these gains by ensuring that full integration is in place. Next slide. We have full integration in place, especially for pediatrics and adolescents. The rationale for integration cannot be overemphasized. When you are looking at easy accessibility, when you want to ensure continuity of care, integration comes in handy because of the squeeze in funding now that we are all experiencing. It's very good that we look at integration. It will help us cut costs. And of course, when we are talking about sustainability, like my colleague in Botswana just alluded to, then integration will have to come into play. Next slide. So for us in country, just like other countries, we also have our national policy guidelines and documents that have given integration a much importance. We have a national strategic framework that emphasizes decentralization and integration of HIV services. We also have our national guidelines for HIV prevention, treatment, and care. It was revised last year, and we dedicated a whole chapter to integration, just to portray the importance of integration. And of course, we have this PHC under one roof. It's a policy, it's a framework that we're also working with. And of recent, in 2022, we got a grant from CDC called NSHIP. That's the Nigeria Sustainability HIV Impact Project. It's a 5-year grant with the sole aim of working in 19 states to ensure that service integration is on the front burner. And we've been able to do a lot. Next slide, using this grant to go to about 19 states to ensure that service integration is happening. However, when you're talking about integration, you need to put certain things into considerations. You need to have your determinants, your government. Do they have the political will? Do you have policy documents on ground? Is there enough funding? And of course, do you have enough human resources? You need to look at some other moderating factors like the health workforce, the training of the healthcare workers, the data management system. These criteria are very important for you to say that, oh, you've achieved integration. And don't forget about the challenges that you will face at the individual level, organizational level, policy level, and program level. Hence the need for constant advocacy because you need other key stakeholders to also play along and to ensure that we are all working together. Next slide. So for us, what we developed in NASCAP, we developed a framework that really helped us as a country to see that a lot is happening. When you're talking about integration, we had to classify integration into full integration, partial integration, and no integration at all. What do we mean? When we say full integration, it means that the ART clinic fuses into the OPD clinic. There's no standalone clinic. screening and management of clients is done under one roof. If there are complications, of course, referrals are being made. And luckily enough for us as a country, our primary healthcare systems are already fully integrated. Should I say by default, because of the way our primary healthcare is being structured. For our secondary healthcare, some of them have full integration, but about 50% of them are still operating partial integration. What do we mean by partial integration? As you can see clearly, they still have standalone ART clinics, they see patients, and then referrals are being made. And then you have some institutions that don't have integration at all. Most of our tertiary institutions fall into this cadre because of the high level of specialty taking place in those tertiary institutions. So this is how we've been able to categorize integration into various models. Next slide. And NASCAP has gone ahead to ensure that we implement this integration we're talking about. We have a policy, like I've alluded to earlier on, we are collaborating with the National Primary Healthcare Development Agency. They have really done a wonderful job as we speak. They've trained over 60,000 healthcare workers, talking about capacity building in the primary healthcare, and they are doing excellently well. We also have tools. We have developed our XOPs, we have our frameworks for service integration, we have our service delivery manual, operational manual for service integration as well. And these documents have really helped us in training a lot of healthcare workers. For us, we also leverage on the ECHO platform where we used to build capacity of healthcare workers, because you can't talk about service integration without building capacity of the healthcare workers. We also leverage on our mentorship program that we have in Nigeria. It's unfortunate that for the CDC states, supported states, the mentorship program is no longer working, but we still have Global Fund supporting other states where we have clinical mentors that are helping us drive the service integration mantra down to the LGS level. Next slide. Still on implementation approach, we have on service delivery models, we have our DSD still working. We are introducing adolescent-friendly health services across all our primary health centers, and this has really helped us. Currently, I'm in Zimbabwe with my Nigerian team. We are learning about the Zandiri model, and we're learning a lot. We want to see how we can go back to Nigeria and see how we can really make a push when it comes to adolescent-friendly services. And currently, some of our primary health centers already have adolescent-friendly services. We're trying to see how we can push that a little bit up. You cannot talk about service integration without collaborating with our CSOs, talking about the NEP1, the ASH1, and the adolescents and young persons living with HIV. They are very key in helping us create demand for services and to ensure retention. And in the primary health centers, we have what we call the Ward Development Committee. These are a certain group of persons that are domiciled at the LGA level. We are collaborating with them to ensure that they create awareness and also help in tracking defaulters. Next slide. So what has been our achievements? We've been able to increase the number of primary healthcare centers that are offering pediatric ART. Our EID has increased. As at December 2023, for the national EID, we are 18%, but as I speak, we've moved to about 55% because we are exploring all available means to ensure that we get these children and adolescents treated wherever they are. And we have also helped increase our retention through peer-led support groups and adolescent-friendly clinic hours. Like I said, we are in Zimbabwe trying to learn more so that we can go back and see how we can push this up a little bit. And also integration of HIV services into the primary health reviews and supervision tools at state and SGA levels is something that we've achieved. However, the challenges we are still having is that at the primary healthcare center, you still have human resource constraints. We still have stigma, lack of adolescents self-care, issues of confidentialities in some of these primary health centers, hence the need for training and retraining of our healthcare workers. Now, we're also having insufficient ROTKs for testing in some of these primary health centers, and data is still an issue, especially the quality of data coming from these centers, hence the need for the training and retraining I talked about. Next slide. So what are our recommendations? Integration is the way to go. We've started it in Nigeria and we're beginning to see some of the benefits. We need to also strengthen collaborations with all stakeholders that are in this space. We also need to increase our investment in adolescent-friendly health spaces and peer support networks, especially in the LGA level. We are not there yet, but we've started the process. And of course, we need to improve supply chain management, especially for diagnostic tools and rapid test kits. And we need to continue the mentorship program and also ensure that there's continuous quality improvement happening as the PHCs. So thank you so much, and thanks for your attention. Over.
Ok, merci Dr. Etiobio pour cette présentation et avec vous, nous avons donc terminé cette séquence de présentation des cas, des expériences pays. Nous avions commencé avec Dr. Cordelia de l'Ouganda, ensuite Dr. Lynn du Botswana et nous terminons avec vous. Nous voulons vous remercier tous les trois pour cette présentation, ces contributions qui ont notamment mis en avant l'importance de la volonté politique dans la réussite des questions d'intégration. Les trois présentations ont également mis en avant un certain nombre de questions qui sont indispensables pour réussir cette intégration de services dans différents pays. Ce sont notamment les questions de financement, la question de la complémentarité entre les acteurs avec la valorisation de la plus-value des acteurs communautaires, le travail sur la nécessité de prendre en compte le besoin de ressources humaines qualifiées en quantité pour faciliter cette intégration, le point d'attention sur la stigmatisation et la discrimination qui peut aussi être un frein sur le terrain, et notamment la question de la mobilisation des acteurs, incluant notamment la mobilisation des adolescents et jeunes sur les questions d'implication et de leadership. Merci encore à vous trois et aux différentes équipes qui ont contribué à ces présentations sur les expériences de vos trois pays. Alors, sur ce, nous allons passer à l'autre étape de notre jour 1 de ce webinaire. Donc, on donne la parole d'abord à Dr. Edouard qui va nous orienter vers les sessions de travaux de groupe. Dr. Edouard, over to you.
Yeah. Thank you very much, Rodrigue. Merci beaucoup, Monsieur Rodrigue. Participants, thank you for keeping with us and following those three country case studies. We're going into something a little more interactive, a lot more exciting. We're going into breakup groups, and I'll invite Isaac to give some technical guidance on how we are going to split up into the three groups that are going to discuss in depth those three case studies. Over to you, Isaac.
Merci beaucoup. Thank you very much, Dr. Edward. Some guidance for us that would want to participate in the breakout rooms. I'm going to open up the breakout rooms and you'll receive a notification on your device asking you to join either Botswana, Nigeria, or Uganda. So you can join Uganda country experience by selecting Uganda and you'll be able to be taken into those breakout rooms. And I'll create the breakout rooms now. You should be able to receive that notification right now and be able to do that and join the sessions now. Thank you. The breakout rooms are open. You probably have that notification. select the country where you would want to go and listen into the breakout rooms. We will not have interpretation in the breakout rooms because logistics. So just join in. We'll try and see how that works there. Thank you. So if you can still hear my voice, it's likely you haven't joined the breakout room, any breakout room. Kindly select the breakout room that you would want to join. You should be able to enjoy the discussions. If I wait 2 more minutes and no one is joined those, I will automatically assign you a breakout room and you can join the discussions in there. Thank you. I would send you where you want to join. If you need any help, just unmute. I will support.
Isaac, I need to move to Botswana.
Edward, I'll send you to Botswana. You should receive a notification now being sent to you.
Okay, seen it. Thank you.
Thank you. Anyone else that needs help, if you can hear my voice, it's because you haven't joined the breakout rooms. I am here to support you. Just unmute and tell me where you
Please send me to Uganda.
is. This Jackie?
Yes, please.
Isaac,
Jackie,
please.
let's one at a time. One at a time, please. One at a time, please. Jane, where do you want to go?
Jane Nabalons, I would like to go to Botswana. Thank you.
Sent you a message. Jackie, I've already sent you.
You sent me Botswana and I said not now.
Let me move you. Let me move you. Just trying to search for
Thank
your
you.
name.
Isaac.
So, Jackie, you want to
here.
move to? Just a minute. Jackie, you want to move to which place?
Uganda. Uganda, please.
Sent you to Uganda. Yes, Shafiq.
Botswana, please, Isaac. Thank you.
Yes, Shafiq. Sent you to Botswana. Anyone
This
else?
is Janet. This is Janet.
Yes, Janet.
How do we get the questions to the breakout rooms? Because I tried
You
to
have to have
flash, but
someone to screen share there. You have to get someone to screen share there.
How?
Send it to one of our teams to screen share there. I'll be moving people around. Please, yeah. Join one where Eleanor is not, and then you can work out something, you, Dennis, and Eleanor, as I move people around. Anyone else that needs support in moving to a breakout room? Anyone else?
Yeah, send me to the Nigeria.
Just hold on. Who is that? Is that Margaret?
Yes, Margaret.
Okay, Margaret, I've sent you to Nigeria. Anyone else?
Edith to Uganda.
Edith? Edith, I'm trying to search for your name. Did I send you elsewhere, Edith?
Yeah, you sent me to Nigeria and I declined. Send me to Uganda, please. Edith Namlema.
I've sent you to Uganda, Edith.
Thank you.
Anyone else that needs support? Edith, I've sent you to Uganda as you have requested. Please join. Anyone else that needs support?
Johannes to Uganda, please.
Johannes, sending you to Uganda shortly. Johannes sent you to Uganda. Anyone else that needs support? Anyone else that needs support? Anyone else
Yes,
that
please
needs
add
support?
me to Nigeria.
Chinye,
Yes.
just hold on, let me find your name. Chinye, I've sent you to Nigeria. You should have a notification. Susan Opono.
Hi,
Opono
please send me to
Joshua.
Botswana.
Edson, sending you to Botswana. That is done.
Thank you.
Anyone else needs support? Anyone else needs support?
Please resend. I failed to click on it. Plopped up.
Just hold on. Let me see. Edson, just stay online. I sent you to Nigeria. It's in Nigeria.
Botswana, please.
Edson.
Botswana.
So I'll first move you back to Uganda, and then I'll move you to. I've sent you to Uganda. Have you received that notification? Let me send you now to Botswana. Please join. Anyone else that needs support and being moved around? If no more support, I'll just move you around so you're able to join any of the other countries. If anyone else needs to join the breakout session, kindly unmute and I'll support you.
I got kicked out the last time I tried to join Botswana. Please send me to Botswana.
Edson, this is Edson,
Yes.
right?
Yes.
Where were you sent, Edson?
I was sent to Uganda. When I tried to join, then I got kicked out. So I had to rejoin the meeting.
Just hold on, I'm looking for him. Let me just find your name.
Even if you put me to Uganda, it's still no problem.
No, where do you want to go? Sorry, Edson?
Botswana. Botswana.
So, and I've sent you the invite. Thank you. Please join.
and also, okay, thank you. So I was
We are out of
then
the breakout
that at
room.
program levels, program, there are focal persons for each district, health district. And those focal persons, they are aligned to the quality improvement program. They are also aligned to they are the people that are in contact with the communities, because there's a connection, like you were talking about NAPA. NAPA is supporting a lot of CSOs. And through those CSOs, there's connection between the facilities and the community levels. So that way, the focal persons are able to determine or verify or establish how happy or how satisfied the clientele are. So as it is, what happens is that through the CQI, through the health inspectorate, through the quality assurance unit, we are able to address all issues that I have to do with patient satisfaction. Thank you.
Yeah. Thank you very much. Thank you very much for, all that sharing. Ladies and gentlemen, welcome back from the breakout rooms. I know time wasn't enough for us to have, to share all the experiences that we had, but I hope that collectively we've been able to harvest quite a lot. I would like to quickly move us to to sharing any highlights that came out of the breakout room. So we should all be back in plenary, and which group would like to volunteer to go first? Should we just go down the list as it is in the agenda? Uganda, are you ready to share?
Janet, are you ready?
Yes, Patrick, we can hear you.
Okay. Our reporter is Janet.
I just need one more minute to put one or two things together.
Okay.
I hope someone else.
So, Dr. Edouard, can you hear?
Shafiq, are you good to go?
Yes, I am. Give me a second, please, and I will upload these slides. And Edward, I'm sorry, I didn't see your template until after I'd already started. So I have a slightly different format, but it's not a big deal. Let me share now. And I apologize if there's any typos. I hope you can see those slides, colleagues.
Yes. Yes, we see them. Thank you.
Great. So this is the Botswana group feedback, and we had a good discussion with the opportunity to talk to colleagues from Botswana to share their feedback and thinking. So the first question was the practical steps country has taken to operationalize integration of HIV into primary health care. And we learned a little bit about the history in Botswana. First of all, Botswana has one of the oldest HIV programs on the continent. So there's long been a bit of a mix in terms of service delivery. Initially, HIV clinics were quite separate from the main health service, despite the fact that primary care is a sort of a linchpin of Botswana's health system and the healthcare model in the country. HIV services were quite vertical. This is changing. And increasingly, HIV services are being integrated into outpatient care, but it's really context dependent and determined by a range of factors, including stigma, capacity in a particular setting that determines the extent to which this integration can happen. This being said, even in a vertical program, there is a strong emphasis on patient-centered care. So care is always comprehensive and wrap around. You don't have to go to multiple places to receive comprehensive care. And you can get all of your sort of care in a one-stop shop approach, even if it's a more verticalized HIV clinic that you are attending. And I think that was an important take-home point and message to take away. We didn't have a lot of time to discuss peds, but pediatrics is more challenging. There are some facilities and health centers that are now doing more integrated pediatric work. But there still remain centers of excellence in the country that sort of, keep the capacity and the expertise in a more localized place. So it's a little bit different for peds than for adults. And how have service delivery points been restructured to enable integration? I think another important point that we learned, which is actually quite relevant for the previous question as well, is that Botswana is a country the size of Kenya with a population that is half the size of Nairobi. So you have a very sparsely distributed population, which creates some challenges on the ground, and has resulted in a setup for service delivery that is, one of our colleagues called it haphazard, but I think it's more that it's quite varied, diverse, and context specific. Now Botswana has learned a lot from the rollout of a public health HIV program. It's, as I mentioned, one of the oldest on the continent, and that has allowed for a lot of mistake making, but a lot of lesson learning as well. And as a result of that, evolution. So I think the integration process is still happening. We will learn more from this. There's a point that I wanted to add here, which I didn't have time to note down clearly, and that is around the fact that the HIV clinics, the patient population, partly because Botswana was one of the first to initiate a treatment program on the continent, the patient population in Botswana is one of the oldest HIV patient populations on the continent. So you have a lot of clients who are now old enough to be seeing more and more non-communicable kinds of diseases. And that has led to a natural synergy between HIV services and chronic healthcare services. So increasingly, HIV programs are learning how to manage non-communicable diseases, and this could be a valuable model for the future. How do M&E systems capture data on integrated service delivery, and how is this used? I think this is, again, watch this space area, because at present, the M&E systems are still quite verticalized and not integrated. So there are separate registers that, even if a clinician is working in an integrated center, there are still separate registers that clinician would have to fill in to report on HIV versus other health reporting indicators. However, Botswana has developed a new integrated M&E framework. I think that's quite exciting. And colleagues, if you could share that, it would be really lovely to see how you're thinking about this integrated approach. And the idea behind this is to alleviate the burden of reporting on frontline workers and to create an integrated set of data from the get-go. So previously, integration was happening at the back end where people were looking at data coming from different sources. But an integrated new M&E framework would allow that integration to happen at the point of service delivery and allow linkage between, individual clients and the related indicators that we're collecting. And I think that will create an opportunity for a much more sophisticated type of analysis that can actually show you how clients living with HIV are faring against specific other indicators that we're using, rather than looking at those sets of indicators independently. And then finally, we didn't have time for all of the questions, but we did get to number 4, which was about innovations and adaptations that have improved quality and client experience. So there is a directorate in Botswana that monitors facilities for quality and has set up CQI processes and mentorship programs to enhance and ensure ongoing quality of care. At the program level, there are focal points that are linked to the quality improvement initiation and can make sure that directives coming down from, or learnings rather, coming through that quality improvement, those quality improvement activities are shared with other partners, e.g., CSOs, other community organizations, to try to ensure that client satisfaction and quality is always maintained and reinforced. Apologies for spelling mistakes. Apologies if I've missed anything. Please, colleagues in the Botswana group, chime in and fill in the blanks.
Yeah. Thank you very much, Shafiq and the Botswana group for the sharing that experience. I will quickly jump to Janet. Janet, I hope you can run us through this in 3 minutes. Any pending inputs, I think, will feed into the following panel discussion. But thank you very much, Shafiq, for that. Janet, are you set? And as Janet's slides come up, all rapporteurs, kindly share your slides with Dr. Eleanor.
Dr. Edward, can you see my slides? I feel like I'm sharing.
Yes, we can see them. Just waiting for them to transition into a slideshow.
Okay.
Walk us through in about 3 minutes. Thank you.
Okay, I am trying to remove all these hindrances. I did not do the best of everything, but I think I'll move with what I have. So I am representing the team that was in Uganda, and we had a few practical steps that we were able to identify. And one of them was really the national level trainings and regional trainings that were cascaded down to health workers. And one of our members, Margaret, was very, very vocal in talking about community sensitization and how the communities were involved and brought into the integration processes. So this was a collaboration between the health workers and the communities. So the communities got to know exactly what was going on, what integration means, and how facilities will be rearranged to offer integrated services. And the approach was made more to buy in so that the community does not get frustrated when they come to health facilities. So I found this was a very good approach to have communities involved, and I'm very aware that services are changing, but they're changing for the better. And we also had a mention of mentorship and the mentorship programs. And it was also mentioned that these mentorships were not only done for health workers, but this extended to the leaderships, to the community leaderships, and also to the civil societies that were also involved in the mentorships and in the trainings, which was good because that means an umbrella of people are involved in giving these health services. We also were taken to the practical guide that was developed and disseminated to all levels, national level, community level, and also and facility level. So this was more of a guideline of exactly how integration is going to happen from the beginning to the end, more of a step-by-step process. And this was disseminated timely, so that by the time integration happened, people were all aware, and this was officiated by the permanent secretary. So the leadership still was very strong. There was also mention of an advisory board that was put in place, and this was meant to keep advising the integration as it's going on, as well as ensuring that the best decisions are being made for the country. And this was also complemented with a task force. So this was a very good innovation to make sure that we're not making grave mistakes as a country. There was also a country that had mentioned data collection and real-time monitoring that was implemented, and this was really to inform decisions as the integration is happening, and helping adapt strategies that were useful, and then drop strategies that maybe were not yielding much. And I had already mentioned the community sensitization that was very key to have buy-in from the community. When it came to what was restructured that helped to enable integration and some of the challenges that were faced, it was very clear from the different countries that were in our group that every country is at different levels, and one of them talked about having clear integration centers and having repurposed infrastructure that was done to especially incorporate maternal child health with other services. And some of these services already were put into clinics that were already existing. So, for example, I think it was Zimbabwe that was talking about their maternal child care having very strong now PMTCT services as well as cervical cancer screening, and then they're slowly incorporating NCDs as well. He mentioned that it was still a work in progress, but they had started incorporating hypertension, diabetes, and other NCDs into the integration process. One of the challenges was, although training was going on, there was really insufficient training for all staff. And this was mainly due to funding limitations and probably supervision issues. And this caused those who were trained, just in case they had a day off or they had other commitments, the clinics were left hanging because the people who are manning were not conversant with what to do. So really the training aspect came out clearly that there was still need to train as much as possible and to source for funds for that. There was also, sorry? Okay, I think that's not for me. There was also a country that had electronic record systems that were being implemented, and this was mainly to improve data capture and integration. And whereas one was having an electronic data system, another was having a very big challenge because they were still very much paper-based. When it comes to the monitoring and evaluation systems, many of the countries had talked about lacking clear indicators for vivid integration into the M&E frameworks, and this really lacked a comprehensive data quality, but improvements were underway because that challenge was noted. One country had mentioned new monitoring tools that have been incorporated, especially for non-communicable diseases, and this was being collected alongside HIV data. But again, most of it is still paper-based. So the expectation is to have an electronic record system to enhance data collection and reporting. Innovations or adaptations that have emerged because of integration. Really, we can't run away from leadership at all levels of government. Like I had mentioned earlier, one of our colleagues had talked about the leadership from the top most, which is the permanent secretary all the way down to community leaders being involved. So this innovation has really facilitated integration. One of the countries I talked about being able to digitize their records, and this was able to, this facilitated streamlining of services and really reduced paperwork. I had talked about the community engagement and them being involved in decision-making, were key enablers. Government policy support was adequate, and for some countries, but funding was still crucial. And a barrier was something I mentioned earlier, training. Sorry, we didn't have enough time. By the time we had reached, I think we're being flashed that we had 1 minute to go. So this is a few things that I had gathered from the discussion. Was there one thing? Let me just quickly check my notes. Maybe a team member could supplement. If I remember something, you have said that we can put it in the chat, so I'll do so.
Yes, sure. Thank you very much, Janet and the Uganda team. Let's quickly go to Nigeria. And for all rapporteurs, please feel free to make any additional edits before you share these with Dr. Eleanor. Nigeria, over to you.
Great. So sorry, just trying to properly share the slides. But Dr. Hyman, do you want to come in to walk through the two slides?
Stephanie, I don't know if you can go ahead because of my internet issues, but if the team can hear me, I can proceed. But I'm afraid because of my internet. Over.
So far, it's clear. So go ahead and I can jump in otherwise.
Okay, great. So for the Nigeria team, just to appreciate the team members for the great work, and it was quite interactive. We looked at integration strategy and implementation. We talked about some practical steps, the developed national service integration policies, frameworks, manuals, and training packages that we have in Nigeria. We also talked about the gradual rollout involving multi-stakeholders engagement, issues surrounding tax shifting, an on-site clinical mentorship program that we have has made integration to be successful. And then the integration phases that we classified as either full, partial, or non-disclosure. And then the second thing we talked about was about youth and community engagement. Here we talked that working with networks of recipients of care, as they want to be called now, but we still call them people living with HIV, especially youth, to reduce stigma and discrimination, and to guide the integration process. I mentioned the OTZ program that is very active across the facilities we have in country. However, we are trying to see how Zantiri can come in and see how we can leash on the community side engagement, because that aspect is missing currently. And also We have developed the age-appropriate disclosure guidelines. We have our SOPs, and we've rolled them out. And this was inspired by our visit to South Africa, the Kids Alive program. We were able to adopt a lot of strategies on how to go about age-appropriate disclosure, which we are using now in country. The third thing we talked about was the health system strengthening and capacity building, some of the innovations. We are really leveraging on the ECHO platform. We are using it for ongoing capacity building, especially around stigma and issues surrounding disclosure. We have the clinical mentorship program that came in, and it's a game changer. It has helped us in building capacity of healthcare workers at the PAC levels, at the secondary levels, as well as the tertiary levels. And of course, what was really innovative for us as a country was the ENDA system. We have, it's government owned. We have the back end being controlled in NASCAP. We've not been able to achieve this for over many years, where we rely on what partners are doing, and we have fragmented data systems all over the place. But with ENDAS, we've been able to converge our data systems so that everybody reports through it. And from there, we make quality decisions based on what we're seeing in the data. And we have a separate module inside the ENDA system for service integration, and that has helped us in tracking and seeing what is going on when it comes to service integration. The workforce constraints that we have in country require us to think outside the box. We are being creative when it comes to tax shifting, tax sharing are very essential, because when you go to the PAC levels, we don't really have enough healthcare workers there, but the government have done a lot. Of recent, the Federal Ministry of Health and Social Welfare engaged about 774 fellows because we have 774 local government areas in Nigeria. So their job is to see how they can help close gaps at the PAC levels across the 774 local government areas we have. I think this is what we talked about. I don't know, Stephanie, is there another slide? Okay, great. So the first thing we talked about was service delivery at both the facility and community levels, where we recognize the fact that integration is key, especially at the PAC settings, where we have AROT being provided at the primary health centers, and then secondary health centers, they're also providing AROT. However, at the primary health centers, if there are other complications, referrals are being made, and then leveraging existing infrastructure, the OVC programs from PEMFA, a lot of gains there. We intend to leverage that. Despite the funding squeeze, we are trying to rethink our program and see how we can ensure sustainability across board. PrEP integration still pending. I have to follow up because there was a question that came on the chat box if PrEP is fully integrated at the PAC level. So I have to follow up on that, but it's something that is quite it's noted. And then I think this is the last on partnership and policy. Because of before the funding freeze, we've been working across multi-stakeholders to actualize integration. And so when the freeze came, we were not really perturbed because we are ready for it. We are coordination with NACA and community networks for advanced integration is ongoing, especially for adolescents. So this was some of what we talked about in our breakout session. So thank you, Stephanie, for helping us put this together. Thank you to the team as well. Over.
Thank you, Etiobio and the Nigeria team for that presentation. Thank you, Stephanie, as well for sharing those slides. I know we still have a lot more to share, but we need to cut this at this point. And, for the, I know we're supposed to have a coffee break. I'll seek guidance from Isaac. But at this juncture, I'd like to hand over the stewardship to Rodrigue and Dennis Adoa to walk us through the very last session of the day. Thank you.
Dr. Edward, before Rodrigue comes in, I think because of time, I propose that we go straight into the panel and then end at once. The panel is about 30 minutes. So if the team could allow, we could go straight into the panel and then end at once. Thank you very much. Dennis, I think, is not on the call, so maybe Rodrigue, over to you.
Ok, thanks, Dr. Eleonore. Merci à toutes et à tous pour vos contributions, à tous les participants aux différents travaux de groupe et à tous nos rapporteurs pour donc cette synthèse de discussion que nous avons eu, pardon, dans les travaux de groupe. Alors, nous allons donc terminer notre session de notre journée par un panel.
Is it because
Yes, par un panel. Et c'est pas si Dr. Denis est là. Je ne vois pas Dr. Denis parmi les participants.
Janet, you need to remove your, you're sharing your screen with us. Janet Lubega. Oh, thank you.
Thank you. Merci, Mr. Shafik. Dr. Eleanor, it seems that Dr. Dennis is not on the call.
Okay, that's fine. I can.
Oh, is there that Dr. Dennis? Can you hear me?
It's okay. I can take it on from here.
Okay, over to you, Doctor.
Yes, thank you very much, Rodrigue, and thank you, Dr. Edward, for leading us into the previous sessions. We are going to go to our very last session, and I'm going to invite our panelists to please come on screen if you're able to do so. We have our panelists ready to take us through the questions. Our first panelist is Dr. Shafik Isaje, who was already introduced. Our second panelist is Moses Luwonzo from Uganda. We also have Rodrigue Kofi, who has been one of the chairs for this session. And we have Happy Margaret from AfroCab, who are going to be leading us into the discussions. And I would like the panel to quickly show your video if you are able to do so. Happy, are you on the call?
Yes, Doctor, I am on the call. Thank you.
Great. Thank you very much. Moses, are you on the call?
Yes, Dr. Elena, I'm on the call, but apologies, I can't share the screen.
Okay, that's fine. So we are going to go through a few questions, and the first question is going to go to Shafik. How should we address equity and access challenges for vulnerable populations within integrated models? And each speaker has about 5 minutes to speak. In case any other panelists would like to add to a question that is not allocated to you, please feel free to do so. So Shafik, over to you to take us through the first question. Thank you.
Thank you, Eleanor. A challenging question, of course, because I want to remind us that one of the reasons why we engaged in vertical programs from the very beginning was because of the issue of stigma that marginalized people living with HIV and made it very hard for them to access health services in the public health system. And I know there were lots of other factors, donors that wanted to see results and were pouring money into vertical programming, ministries that were also being pushed by this political pressure to say, no, just get it done, you know, go around the system rather than go through it. But there was also an issue with stigma. And in the early days when I was practicing in Kenya, in Mombasa, I remember being told by the hospital that our HIV clients could not be admitted to the main hospital. Would I kindly put them into a disused wing of the hospital where there was no water, no electricity, and no beds? And the clients could just come there and sleep on the floor with their families who would bring them food. And we could see the patients in that disused area, but this way they would not be interacting with the rest of the hospital. So those were real situations that we faced back in the early days. How can we ensure that those situations do not come back to haunt us as we integrate? And I think, excuse me, the key here is preparation, training, and community involvement. Because at that time, we didn't have strong community actors who could stand up and advocate for themselves. And not just shouting loudly about community engagement, but real engagement that shows really how the community are the holders of so much knowledge, so much information, and add so much value to the way in which we deliver these services. So I would say if there's one thing that we take forwards into an integrated approach, it is placing our colleagues and partners and friends in the communities that are affected right at the center of the planning that we're doing, the trainings that we're providing, and the capacity building of the service providers to ensure that they're delivering high quality, equitable, stigma-free care. So yeah, I think the onus is on us to kind of make sure that as we plan for this rollout, that we do so in a way that challenges some of those perceptions of stigma, perceptions of people living with HIV, which ultimately gets in the way of delivering equitable care to marginalized and vulnerable populations. Well, let me stop there because there may be others on the panel, Eleanor, who want to add to those thoughts.
Thank you very much, Shafiq. Do we have any additional comments from the other panelists before we go into the next question? Great. Thank you very much, Shafiq. You raised very... yes, please go ahead, Rodrigue.
OK. Merci beaucoup, merci à M. Shafiq. Je suis heureux de le retrouver sur ce panel. Je dirais qu'en plus des questions de lutte contre la stigmatisation, de la valorisation du travail communautaire, l'intégration permet aussi de rattraper un certain nombre de choses, notamment le cas des enfants qui sont passés entre les mains du système PTME et qui peuvent être donc rattrapés via d'autres secteurs dans le cas des systèmes intégrés. Et un autre élément supplémentaire qu'on pourrait ajouter, c'est le fait que l'intégration, comme je dis si bien, contribue aussi à optimiser l'affectation et l'utilisation des moyens, des ressources qui sont mobilisées pour éviter de faire des fonctionnements un peu sectoriels, qui quelquefois sont complémentaires, qui peuvent être mieux faits avec des ressources plus prolongées dans la durée et moins de gaspillage. Voici ce que je voulais faire aussi en termes de contribution. Merci.
Thank you very much, Rodrigue, for that addition. We are now going to move on to the next question that is about community engagement, and this is addressed to Happy Margaret. What role can community engagement or or civil society organizations play in supporting and sustaining HIV PHC integration efforts? Over to you, Happy.
Thank you so much, Dr. Elena. I think one of the major roles that the community is playing is capacitation of community leaders and increased coordination with the community and civil society networks in ensuring that we have an integrated health service delivery. Under the coordination of our National Forum of People Living with HIV, which clearly has structures from national to community level, we were able, leaders of the networks of people living with HIV in all our diversities, we were able to be represented and met with the permanent secretary for Ministry of Health for us to get better understanding of the circular when it was disseminated. And through the coordination of NAFOFANO, we really got good understanding of it, because initially, before we got understanding of the circular, we were a little bit resistant to phasing out the standalone HIV and TB clinics. But when we got the information, when it was unpacked, and we really got to understand that it is actually helping us to access holistic services, and someone is looked at holistically, not as a disease, we really appreciated it. And so from there, our participation in decision making regarding integration at all levels has enabled us to also disseminate the same information to the leaders of the networks of people living with HIV at district, but also community level. So coordination, capacitation is playing key role, but also we are developing our innovative community facility service delivery models that will help us to prevent loss to follow up and misappointments of people living with HIV in an integrated service delivery approaches. So that is one of the key things we are doing. And for me, as a leader and also as a staff of AfroCab, we have spearheaded a training of the district of the leaders of people living with HIV from the district-based organizations, so that they also get the same information we got at national level. And remember, these are composed of support groups, caregivers, recipients of care. So all these, if they happen to get all the information about integration, it's going to help us demystify the fears about integration. Some of us, we fear before we see the thing. We fear before we know it. But when we get to know it, that self-stigma we shall manage. And of course, we also engage with the different stakeholders to ensure that when we are integrating, the quality of services also do not get compromised. And we are encouraging the recipients of care to give feedback to the ministry, to the government, because we know we are learning in the process, so that the services can be delivered in a way that is tailored to the needs and preferences of the recipients of care. We are leveraging on the differentiated service delivery models to make sure that we create awareness about integration, but also we are promoting the WHO Stop AIDS package of care for pediatrics and adolescents, so that when services are being integrated, issues around advanced HIV disease does not get lost into non-communicable diseases, because we are looking at these two things are different. NCDs and AHD, they are different. And so we want to respond to both in an integrated service delivery. Thank you. So basically that is what I can say briefly for the interest of time.
Thank you very much, Happy Betty, for those wonderful discussions, the engagement with the community stakeholders from national level to the lowest level. I liked very much the idea of meeting with the permanent secretary to unpack the information that comes from national level as a way of doing away with the resistance that comes with a change. So thank you very much for that. We are now going to move on to the next panelist, Rodrigue Kofi. Can you share examples of how integrated HIV and PHC models have improved continuity of care for clients with the comorbidities like TB, NCDs, and Kofi works with an organization that works across 11 countries in West and Central Africa. So you bring on board a very good and rich experience from different countries. Over to you, Rodrigue.
Okay, thanks, Dr. Eleanor. Thanks for your kindness. Alors, effectivement, comme ce matin, cela a été relevé dans certaines interventions, les questions d'intégration de services sont des éléments qui sont très perceptibles dans beaucoup de pays, déjà avec l'exemple des programmes PTME qui sont mis en place depuis un certain nombre d'années qui donnent des résultats, même si on peut encore largement mieux faire. Si nous voulons partager quelques exemples, modèles des choses qui se font dans différents pays dans lesquels le réseau grandit ensemble et ces organisations sont engagées, pouvons peut-être cibler 3-4 pays déjà en gros pour le temps que nous avons. Je me permettrai de commencer par l'exemple de la Côte d'Ivoire où je suis. L'un des modèles d'intégration que je trouve personnellement réussi, c'est tout le travail qui a été fait en lien entre le ministère de la Santé et le ministère de la Famille, des Affaires sociales autour des centres sociaux. Dans ce pays, il y a les centres sociaux donc, qui sont donc des services qui offrent enfin, des entités pardon, qui offrent des services de premier niveau pour tout ce qui est soin des enfants. Donc, tout ce qui est pesé, tout ce qui est malnutrition, modérée, tout ce qui est suivi de routines telles que les vaccinations quelquefois. Et depuis donc un peu plus de 10 années, il y a un schéma d'intégration qui permet à ce que les moments où les jeunes dames qui arrivent dans les centres sociaux pour faire peser leur enfant ou pour mesurer le MUAC ou pour les vaccinations, peuvent aussi arriver là et permettre aux différents travailleurs sociaux qui sont là, quelquefois des communautés qui y travaillent en termes de permanence, qui permettent donc au-delà de la simple consultation, au-delà des activités d'autonomisation des femmes qui sont mises en place, qui permettent aussi de faire le lien sur les questions de santé. Et ce schéma permet non seulement d'offrir des soins primaires basiques aux enfants ou aux jeunes dames en âge de procréer, mais a permis et permet aussi de rattraper, comme je disais tout à l'heure, un certain nombre d'enfants qui ont échappé au programme PTME parce que soit la maman a déménagé, soit parce qu'il y a des questions de stigmatisation, donc qui ne va plus dans la zone de suivi, ou pour question d'incompréhension d'informations pas suffisamment complètes, qui n'a plus fait le suivi. Donc, à partir donc, du centre social, on peut rattraper un peu cela et les remettre dans le système de santé, soit au niveau des hôpitaux publics ou au niveau des structures sanitaires, au niveau des acteurs communautaires, et même aussi aider à faire le rattrapage de certains enfants qui sont perdus de vue, tout en offrant d'autres types de services qui ne sont pas forcément des services VIH comme port d'entrée. On a aussi des modèles d'intégration réussis. M. Shafik le relevait tout à l'heure sur la notion de la valorisation de l'expertise et du travail communautaire. Et cet exemple se voit notamment dans deux pays que nous avons, par exemple le Togo et le Burundi en Afrique centrale, le Togo en Afrique de l'Ouest. Donc, il y a déjà cette collaboration entre les acteurs associatifs de premier plan de ces différents pays et les différents ministères, notamment les PNLS qui sont impliqués, qui ont permis donc de développer des schémas d'amélioration déjà des modèles des modules pardon, de formation des soignants qui font que, si je prends l'exemple spécifique du Togo, vous avez aujourd'hui des renforcements de capacités qui sont faits par du personnel soignant public, par donc, les acteurs associatifs, qui font qu'on a des acteurs de structures sanitaires publiques aujourd'hui qui ont une vision beaucoup plus large, qui à partir donc de l'offre de services ordinaires qu'il offre. Il y a donc cette ouverture dans une amélioration de la compréhension des besoins de la cible enfants et adolescents nés ou vivant avec le VIH, aussi les jeunes dames en âge de procréer, et aussi le lien avec les autres éléments de co-infection, notamment la tuberculose, le traitement des autres questions du cancer, notamment le cancer du col de l'utérus chez les patientes sous traitement ARV. Vous avez aussi cette intégration qui est aussi poussée sur des questions de santé sexuelle au-delà de l'accompagnement. Nous avons le cas du Burundi avec tout le travail, avec un grand programme de travail qui fait qu'aujourd'hui, on est en train vraiment d'arriver au point qui peut-être était la meilleure option, de quitter le schéma vertical qui considérait que la connaissance est toujours au niveau du sommet que la descente, mais adopter une approche beaucoup plus horizontale qui permet de se dire qu'il y a des connaissances et des expertises à tous les échelons de l'offre de service, et y compris au niveau communautaire, et comment est-ce que la porte d'entrée communautaire peut être exploitée pour développer des approches, des modèles de soins qui peuvent avancer. Et je terminerai, vu le temps qu'on a, sur une autre approche d'intégration que je trouve aussi très intéressante, et qui peuvent aussi faire l'objet de compréhension. C'est notamment quand on prend l'exemple des pays actuellement dans le Sahel, avec la crise que connaît donc ces régions du Mali, du Burkina notamment. Vous avez, si on prend l'exemple du Burkina Faso, vous avez dans la zone de Bobo-Dioulasso, donc cette zone qui est amenée donc à accueillir un certain nombre de populations déplacées, dont certaines personnes ont fui des zones de conflit, donc les sites de prise en charge, les sites d'accompagnement, pas que VIH, bien sûr, et qui arrivent là. Et vous avez des acteurs de soins, notamment associatifs, qui ont développé depuis un certain nombre d'années des structures sanitaires qui sont ouvertes, pas spécifiquement VIH, mais qui sont ouvertes sur un certain nombre d'activités de santé, et pas que cliniques de santé au sens général du terme, qui s'ouvrent à toutes les populations, qui permettent à tout le monde de venir s'inscrire, de pouvoir venir faire des consultations, bénéficier de services dans la limite de leurs possibilités, bien sûr. Et donc, ce type de modèle de soins font que pendant ces contextes, on a par exemple notre partenaire de Bobo Dioulasso qui réussissent aujourd'hui à rattraper un certain nombre d'enfants et d'adolescents et leurs parents qui ont dû fuir ces zones pour arriver là et qui sont donc directement intégrés dans le cycle de soins en réduisant les risques de stigmatisation puisqu'elles ne sont pas cataloguées comme uniquement associations ou structures de prise en charge des personnes nées ou bien avec le VIH, mais elles sont aussi un système des offres de services de communautaires qui permettent donc de rattraper donc ces populations déplacées, de les réintégrer dans les soins, de réduire donc le risque de résistance, de perte de vue dans les soins, et tout en permettant une collaboration avec les autres acteurs sur le terrain. Donc, voilà un peu en quelques minutes ce que je peux dire sur la question de l'intégration en termes d'exemples que je peux proposer dans quelques minutes. Over to you, Dr. Neil.
Thank you very much, Rodrigue. I'll pause there to see if there are any additional comments from the panelists before we go into the last question. Okay. Thank you very much, Rodrigue, for sharing with us that cross-country experience. I liked the idea of the associations of healthcare professional clinics that provide services in war-torn zones. And that actually brings in another element of integration that we need to think about. How do you provide integrated services in a war-torn area? So thank you very much, Rodrigue. And lastly, and very important, data in integration. And Moses Luonzu is a biostatistician working in Uganda, and who is been very instrumental in working with the rest of the team to see how we can harmonize data systems in Uganda. So Moses, how are you ensuring data harmonization and interoperability between HIV-specific and PHC information systems? Thank you, and over to you, Moses.
Yes, thank you so much, Dr. Elena, and thank you, colleagues, for being patient. I'll try and wrap up basically how better this can be done. This can be done through through following the following approaches, starting with the first and most important, being from policy and governance alignment. Here, what am I trying to say? We need to ensure that both the HIV and the primary healthcare data priorities are aligned under the National Digital Health Strategy. Alignment so that to ensure that, yes, there's no duplicacy, we can have these easily retrieved or attained, but making sure that there is an alignment and we can easily have a trackable one tracking system throughout the process of M&E. Most important is also under policy and governance to ensure that there is the stakeholder coordination mechanism. We need to establish a multi-sectoral data governance task force from the different departments, let it be even implementing partner or facility representatives. These support us to guide the interoperability priorities and standard. Under pillar number 2, which is also very, very important, it's specifically we need to standardize data elements and indicators. This whereby we can choose to say that we ensure that we have a harmonized data dictionary so that all the HIV and primary healthcare indicators are uniquely identified, and this helps at that process of trying to go the digital way. Number 3 is under the element of ensuring that we develop technical interoperability mechanisms. Here, what am I trying to say? For example, one, we have like what we can talk of data exchange platforms, meaning, let me say from the lab, I can easily pull information from the primary health care with the chronic care unit. I can share this information with, let me say, someone in the ART clinic. And most important, this can be much more easier if a country has developed a unique patient identifier that we can easily track these clients across the different healthcare service provision point. Let it be at chronic care, let it be at clinic, we have that unique identification. Most important, that is under pillar 4, is integrated digital tools. We know very well that we have quite a number of digital tools. For example, in Uganda, we have the Uganda EMR, we have the Clinic Master, we have now eAfya. Unfortunately, some of those platforms, the clinic platform, those electronic platforms were not integrated. They were disease specific. So part of the way forward is to see that this clinical, the electronic platform is integrated. Basically, it can easily be used across all services. Just like right now, we can easily speak of the Clinic Master and the other being eAfya that we are onboarding. Most important, under 5, we shall speak about the data quality and the use cultures. We need to have, first and foremost, routine joint reviews. Joint reviews meaning as HIV program alongside with under primary healthcare services, we go ahead and conduct a joint meeting rather than having parallel sessions. And I'm glad that as a meeting, we have been on, as a ministry, we have onboarded having joint reviews whereby Dr. Elena will be sent somewhere, but she's mandated to provide a comprehensive performance review and mobilize it. That is comprehensive for all diseases, not only HIV. And also part of elements of capacity, we have to look at capacity building. We need to train all our health workers on integrated data use rather than being specific to our program. And as we provide feedback, let us try to provide feedback in the aspects of integration. Finally, I'll speak to the elements of scaling up. I know we're just at the inception stage, but the ask is that as we roll out the integration, The ask is that let us try to roll it out in a progressive way. This will help us to learn the lessons rather than at times moving full scale. And it has been proved to be kind of more easy to adopt and adapt, but it helps to learn lessons and we improve along the way, just like the way we have tried to move on from the element of we first do the regional TOTs, we get feedback, we do district, we do get feedback before we go to facility level. So basically, Dr. Elena, those are part of the ways that we can onboard to see how we can try to integrate and harmonize our systems for M&E. Thank you, and back to you, Chair.
Excellent. Thank you very much, Moses, for those very insightful discussions on data, the importance of allowing ourselves a learning curve so that we are able to do this progressively as we learn. We are now going to open it up briefly before we end for any questions to the panelists. You can raise up your hand if you have a question, and we will ask the panelists to respond. So it's now open for anyone who has any additional questions or comments to make your submission. Over to you, team. Please raise your hand and I will be able to pick on you. Okay, so as we wait for members to raise their hands, I also wanted to ask the panelists just a quick question on the financing for integration. How best can we think about financing the integration efforts, especially now that we are seeing the resources reducing? Any quick comments on that as we wait for other members to ask their questions? I will also check in the chat. Anyone who would like to give some hints on what you're doing to manage resources for the integration, especially if we are going to go multi-sectoral, like Moses was saying, having multi-sectoral technical working groups. Any of the panelists is welcome to make a submission.
Dr. Elena Moses here, I can at least go first as we wait to just submit part of the innovations that we have onboarded.
Yes, please.
Part of that is, first and foremost, we need to, as a country, we had to go back and made review of the available primary healthcare funding that is coming in from within the government. And then we had to reprioritize the activities to which we are allocating these funds for. Placing into context that yes, we no longer have the external funding, and then how better do we use the funds that are within our coffers? For example, one of the facilities identified a very core resource, which was in form of a human resource. And they had to look within their funds to see how they maintain and facilitate that human resource. These were sample riders, hub riders. So that facility tried to see that within their means and engaging whoever the service provider is, that's the rider, how better they can ensure that there is service continuity, but utilizing the available resource. So basically, it's just one of the elements I can share, and probably we can get more from my other colleagues. Thank you, Chair.
Thank you very much, Moses, for sharing that Ugandan experience, encouraging the health facilities, the districts at that lower level to look at the funding they receive from government and see how it can be prioritized to continue service provision. Thank you very much. Any other comments from any of the panelists before we wind up? Okay, I can see there is a hand. Yes, Rodrigue, please go ahead.
Okay, thanks, Doctor. Merci à M. Moses pour ce point. En addition, je crois qu'il y a peut-être aussi je sais pas comment on le dit, c'est que comment est-ce que progressivement on ne développe plus des financements qui font une approche projet ou une approche programme, mais des financements ou des appuis qui sont plus dans une approche système. Donc, qui visent à renforcer un peu le cadre existant, amener les personnes, les acteurs, pardon, à vraiment, mais vraiment travailler ensemble. Ce qu'on appelle généralement le renforcement des liens. Aujourd'hui, la plupart des pays ont commencé le schéma de la triple élimination dans les différents programmes, donc VIH, hépatite, syphilis, avec ce qu'il y a comme défi structurel. Il faut aussi arriver pour arriver à l'intégration aussi des services, il faut qu'il y ait aussi un schéma d'intégration dans les curricula de formation des acteurs, que ce soit déjà au niveau des curricula universitaires pour ceux qui sont concernés, mais aussi le modèle de formation des acteurs, comment est-ce que dans le renforcement, on essaie d'avoir une approche santé sur les différentes questions et la question de complémentarité qui peut jouer dans la balance. Et le dernier point que je voudrais avancer comme piste de réflexion, c'est vraiment la manière de collaborer. Il faut que nos approches verticales changent un peu, qu'on commence un peu plus à des approches aussi horizontale. Je le disais en avril lors des consultations de l'ONU-SIDA pour son nouveau plan de travail. On a tendance à beaucoup parler de renforcer les capacités de la communauté. Je pense qu'aujourd'hui, les communautés ont développé énormément d'expertise dans certains pays, dans beaucoup de contextes qui ne sont pas assez documentés, pas assez valorisés, pas assez intégrés dans les systèmes. Et arriver à faire cette meilleure valorisation des expertises communautaires permet aussi de voir comment est-ce que dans des contextes difficiles, de belles choses, de belles initiatives ont conduit à des résultats tangibles qui sont pérennes, qui sont durables et qui sont un peu moins compliqués à passer à échelle si on s'y met un peu tous et toutes. Voilà ce que je voulais faire comme élément de contribution, de piste sur votre question. Over to you, docteur.
Thank you. Rodrigue will have the last comment from Shafiq, and then we'll wind up. Thank you. Over to you, Shafiq.
Thank you very much, Eleanor. The last comment, and keeping you all from going home this evening. I just want to say, there's we haven't talked about the elephant in the room, which is the funding crisis that so many of us are facing in our countries, and the urgency of trying to sustain and maintain HIV services, especially for children and for mothers, in the context of that reduced funding. Integration would seem like an obvious solution, and it is the right thing to do for sustainability. But I think what I've learned from this is that planning is critical. Pacing yourself is critical. Phasing this in and learning as you go is critical. And if we jump into it without thinking about some of these challenges, how you deliver chronic care in a primary healthcare facility, which is already understaffed and under-resourced, how do you ensure continuity and consistency and quality of services? How do you engage the community from the get-go to be partners in the delivery of care? All of these things are really important to think about and to plan correctly, because the worst thing we can do is to integrate too rapidly or haphazardly and end up with a bad result. Something that suggests, oh, well, patients are not doing well because of this integrated service. We know that patient care, that quality can be delivered by communities at the primary level, by primary health facilities. We know it's possible because we've seen great examples. So let's remember that, but plan, think carefully, move quickly, but just because of the urgency of the funding crisis, let's not throw out all the learning and all of the good advice that we've heard and move too hastily in a way that ultimately doesn't do a service to the communities and the people that we want to serve.
Thank you very much, Shafiq, for that excellent submission. We don't need to forget the learnings that we've had. It's not all about money, but it's also about how we can reorganize the existing systems to be able to work efficiently for us as we allow ourselves a learning curve. So thank you very much, our dear panelists, for those great submissions. There's a comment before we end. Thank you for the presentations. I would like to hear your comments on acceptance of integration among healthcare workers, challenges in training on specific HIV treatment guidelines along other diseases. So Isabel is asking how we can conduct training for healthcare providers across many diseases now that we are integrating. How is that going for us? Anyone who would like to chip in quickly among the panelists? Happy, Margaret, Moses, Rodrigue, Shafiq.
Yeah.
Okay, Dr. Okay, Moses, let me allow the lady to go first. Please go first.
Yeah, thank you so much, Doctor. I think what is important is information. Once the health workers really get fully trained about integration and they get full information, including the frontline community health workers, I believe they will embrace integration. They may not embrace integration when they don't have information, but when they get information, integration will fully be embraced. And when they are training professional health workers, it's important to also include the community, the frontline community health workers who are always at the forefront of delivering the health services within the healthcare setting and also in the community. So information is very, very important.
Thank you very much, Happy. And lastly, from Moses.
Okay, yes, thank you, Dr. Elena. First and foremost, I know the planning process for, let me say, provision of the training package. Ideally, my assumption is we should get a minimum care package that is simplified to unpack. So so that it's much more easier to provide the basics. For example, elements of screening, the elements of start with this, so that it's not so complex. But you need to also give maybe probably monitoring indicators so that some of our health workers, those not at advanced level, you ask them to look out for some of the signs that may indicate something not right so that we have the processes of referral. That is one. Two, like we said, these trainings, we cannot say we are going to conduct a training and that's the end of the story. We have the plans of ensuring that we have continuous mentorships and coaching sessions that we need to really package and come up with also very clear schedules. This continuous engagement will enable us at least build more capacity, but also build on the confidence of these health workers from cases that are being onboarded. Then three, we can also package very simple CPD sessions that can easily be even onboarded at health facility levels during their sessions. And we advocate for our colleagues to continuously do these engagements to just help and improve better the capacity of our health workers. I know over time with these engagements, it makes our health workforce much more confident and better. Yeah, Chair, that is what I thought through. Thank you.
Thank you very much, Moses. That brings us to the end of the panel, and would like to appreciate all of you who are still on the call for giving us an extra almost 1 hour from our end time. I would like to thank all the presenters, all the session chairs for today. Thank you for a great job. Well done. And all of us for keeping this discussion very vibrant. We'll start at the same time tomorrow, 4 p.m. East African time, 2 p.m. Western Central Africa time, and that would be 3 p.m. 3 p.m. I think for the Southern African, 5 p.m. for the South. Okay, I think I'm confusing it a bit, but I know the Southern African countries are 1 hour behind, so that would be 3 p.m. 3 p.m. for the Southern African countries. We are going to share a code for assessment for today. I don't know if Kalibala is still on the call. I would like to do an evaluation of the sessions for today. I know most of us have dropped off, but maybe, Dennis, are you on the call, Kalibala? Okay, so maybe we will start there tomorrow. We'll start with that tomorrow to evaluate. So tomorrow we'll have our evaluation. At the start, we'll have a recap of all the discussions that we've had today. We will also do a Zoom picture, so come prepared to turn on your video so that we can take a Zoom picture for our records. With that, I would like to thank you very much. Don't miss tomorrow, because we'll be sharing our plans on how the next steps. We are going to form a small working group that is going to synthesize all the discussions, and this group is going to develop a best practices document. We are going to come back to the countries that have presented to document very well the case studies, and we'll put all of this in the best practices document that we'll share. We will also send you a survey. We had thought that we'd send it before the meeting, but we will send it after the meeting to allow you time to consult within your countries, to get back to us on where you are with the integration agenda, and that will still come back to this small working group so that we can put together a package on how we can support the countries with this integration. And lastly, we are planning a follow-on meeting in September to be able to have more discussions on the same topic, and to see if we've been able to get support through this platform to support our integration. And in September, we'll also be picking on other countries to share with us their experience. So thank you very much, everyone, for joining. Have a wonderful evening, a good afternoon, and a good morning. Thank you, and bye-bye.
Thank you. Thank you.
Bye.
Thank you.
Thank you and bye.